I'm Peter Lucas, and I volunteer as treasurer for this august organization. I've been on the board for about 10 years, and this is the our what's called our second Wednesday speaker series, which has been going for several years, where we feature esteemed presenters, and we learn a lot. Tonight, it's going to be Dr. Michael Fine, who will lead us on the pathway from our current healthcare marketplace to a true universal healthcare system. And he'll lead us in discussion about the actions we need to take to make sure that social justice and democracy are built into this pathway. First, I'd like to invite you to volunteer with our organization. There are opportunities in quite a few of our committees, the policy committee, communications committee, fundraising committee, outreach committee. Alternatively, you could just join us for a one-off project or two. Just let us know what you'd like to get involved with. And in the Zoom chat, we are posting a link to our website where you can find the donate button, and then you can navigate to get involved button to volunteer. And while you're on the website, please make a donation if you're able. Every donation helps us move a step closer to universal health care. Our goal tonight is $250. So you can just go to the chat anytime during the presentation, and there'll be a link there to donate, and there'll also be a link to get involved in our volunteer activities. And we will add the resources and information that we present tonight to our website. And you can check out our website to find out what our legislative goals and actions are, our long-term vision, our strategies to move along to a true universal healthcare system with, as our motto states, everybody in and nobody out. So there are lots of good reasons to visit our website. And we will also use the chat to track any questions that you have, which will then be answered after the presentation in the Q&A session. Please enter your questions in the chat at the bottom of your Zoom screen. And also you can click the closed caption icon at the bottom of your Zoom screen for captions. And Dr. Fine requested that I not provide a lengthy introduction, but I can't help myself. In perusing his website, I became aware that he has accomplished in so many fields and endeavors. He's a family physician of many years' duration, a public health official, a community organizer, an author of several books addressing the U.S. healthcare crisis, an international speaker, and a media figure. And that just pertains to his work as a healthcare expert and advocate. In addition, Dr. Fine is a published and award-winning author of novels and short stories, and even a war correspondent. Currently, I believe he's president of Primary Care for All Americans, which is a single-payer organization in the Northeast. At one point, he was director of the Rhode Island Department of Health. He's been the president and board chair member of Primary Care for All Americans since 2023. He's currently the board vice chair and co-founder of the Scituate, hope I got that pronounced correctly, Health Alliance, and he's received numerous awards for his work. And as stated on his website, he believes that we can change the world by empowering, caring for, and educating one another. Tonight, he will tell us how in his presentation entitled, How Primary Care and Community Organizing Can Bring Us Universal Health Care Now. So take it away, Dr. Fine.
Thank you, Dr. Lucas, for that incredibly kind introduction. I'm thrilled and honored to be with you. You know, it's particularly awe-inspiring to be in the same virtual room with Garrison Bliss, whose ideas provided some of the foundation for much of the discussion that you're about to see. When I talk, I try to remember the sort of giants who walked the earth before me, particularly Jack Geiger and Bernie Lown. Jack Geiger, as I'm sure you all know, was the co-founder of the Community Health Center movement in the United States, which now provides primary care to 30 million Americans at 14,000 sites through 1,400 different community health centers, each with their own community board. Now, our challenge is something you guys know about better than anybody. U.S. healthcare is a hot mess. Notice I don't use the word system because we don't have one. We have a market, and this is what the market is doing to us. Our life expectancy is 46th in the world. Our infant mortality is 50th in the world. We have these unimaginable and unacceptable health disparities on the basis of race. Um, the life expectancy for Black Americans is 4.5 years shorter than that of white Americans and 11 years shorter than Asian Americans. Our infant mortality rate Black Americans is 3 times greater than white Americans, and that is 3 times greater than the best achievable rates in the world. We are not doing a decent job and measuring up. And as you all know, it's crazy expensive. More than $5 trillion a year, about 20% of GDP, twice the average cost of other developed nations, rising at almost 5% a year on average, which is twice the rate of general inflation over about 30 years. It's costing us $15,000 per person per year. Commercial insurance is costing $9,000 per person or $15,000 per person per year, enough to buy a new car for a family every single year, and enough to send a kid to college over a couple of years. I live in a community of 10,000. So we spend about 150, or somebody's spending about $150 million a year for our community. The town budget of that community was $43 million. So we're spending almost 4 times as much on healthcare as we are on every other city service. In the state of Washington, that means you spend about $120 billion a year on healthcare, if my math is right, as a state altogether, not just in the state budget, but all your entire expenditure. And that's in a state where your state budget is about 70 billion. So you're almost twice as much as what you spend on every other state service. The root cause of the problem, from my perspective, is our failure to provide primary care to everyone in the United States. Primary care being the only medical service that's ever been shown to reduce cost while it improves public health outcomes. The root cause is magnified by the problem caused by the relatively few people, about 43% of the U.S. adult population, who have a meaningful meaningful longitudinal primary care relationship. And for those of us who want to think that health insurance alone will fix the problem, only about 66% of Medicare beneficiaries had a primary care visit in a single measured year. And that's, as I understand it, about the best health insurance in the country. So health insurance alone doesn't get everybody primary care. That's a critical idea. And it's critical because primary care is public health. The combination, the collaboration between primary care and public health has allowed us to virtually eliminate polio, mumps, rubella, and the many birth defects rubella caused. Until recently, we thought we had eliminated measles, but it certainly reduced the incidence of measles. Our collaboration helped us eliminate rabies, virtually eliminated rheumatic heart disease during my professional life, saved 8 million lives just up till 2012 by reducing smoking, has started to control hypertension and diabetes to prevent heart disease and stroke, which means years of potential life loss to 75 from ischemic heart disease dropped by 64% for over about 30 years. The years of potential life loss from stroke fell by 47%. We've seen a 70% reduction in adolescent pregnancy. We did not do an adequate job, in my view, controlling SARS-CoV-2 or COVID-19, leading to something like 900,000 excess deaths when you compare us to countries that had a well-organized approach. But we still saved 3 million lives and prevented 18 million infections. Our work just on colon cancer screening alone saves about 50,000 lives a year. But because we only get primary care to less than half the population, we still lose 50,000 lives a year to colon cancer unnecessarily. The the triple superpower of primary care is that it gives people an affordable option when they're sick instead of using a very expensive, impersonal, and sometimes not adequately focused on prevention emergency department. It works by delivering effective evidence-based prevention to the population who have primary care. And it works by helping people with chronic disease get the treatments and prevention they need. And the amazing thing is primary care is so amazingly affordable. I was starting to say this before everybody came on. It's about 3.9% of the total health care spend, or $585 per person per year. Uh, Understanding that that's what we spend on average, the cost for an advanced patient-focused primary care, patient-focused team-supported primary care is likely closer to $1,200 per person per year. We save money because the quality of our primary care could be better, but we lose money because we don't get that high-quality advanced primary care, team-based, to every single Americans. Primary care is interestingly similar to the costs of other services cities and towns provide for everyone. Police and fire protection costs on average $525 per person per year. Water and sewer costs on average about $1,500 per person per year, or about 3 times what we're paying for primary care today. And the cost of elementary and secondary education costs about $1,800 per person per year, or something like 4 to 5 times what we're paying for primary care. And that's per person, not per student. Per student, the costs are much higher. Primary care can help reduce health disparities. Lots of good studies show that it's a fairly potent way to do that. It's not perfect, understanding that health disparities have at their base social inequalities that need to be addressed if we're going to reduce or eliminate health disparities. But primary care can certainly begin is the medical service that's most effective at reducing those disparities. Again, remembering that it's the social disparities and our approach to those social disparities that are so critical. We just can't do epidemiologically meaningful prevention until we can address the entire denominator. We can't get rid of colon cancer until everybody has primary care, and those primary care practices are getting people evidence-based colon cancer prevention. We just can't get rid of HIV, which we knew how to do in 2003, until we get everybody in the United States enrolled in a primary care practice and all those people 13 to 64 tested for HIV, and then when positive, linked to treatment and maintained in treatment, remembering that for HIV, treatment is prevention. And 2 days after we do that, the HIV epidemic stops and leaves the United States forever. And so as a result of our failure to provide primary care to every single American, we've lost life expectancy. CDC says the causes of that are COVID-19, diseases of despair, heart disease, and chronic liver disease and cirrhosis, mostly from hepatitis C. But the distal causes, the really important causes that we don't talk about, are income inequality and its consequences, the downstream impact of historical and systemic racism on the personal health of individuals, and most importantly, from my perspective, the shrinkage of primary care utilization, so we can no longer, from a public health perspective, address the denominator. We have no way to get evidence-based prevention to every single American because we don't have a healthcare system. We have a market that just addresses the people who choose to walk through the door. So our challenge and the opportunity is to build a healthcare system that's for people, not for profit, and that starts by providing robust primary care to all Americans in every American neighborhood and community. And the opportunity is to build the social movement that we need to get that done. Now, that's what Primary Care for All Americans works on. We recognize that there's a strategic opportunity to provide primary care to everybody and use it as a basis to to get community organizing done. So we mobilize our communities, and we can do that because primary care is affordable and effective because it's an essential service, just like police and fire protection, just like roads and bridges, just like clean water and local public schools. And because the costs are on the same magnitude, the same order of magnitude as those other essential services. These services are things communities can do for themselves. Why can't communities provide primary care to everybody? So, as we think about this, we think there's a way to make this or to help this happen, because health happens when communities engage, create affordable health care by getting primary care to everybody, and use the savings that creates to improve housing, improve education, improve public transportation and parks, and create community organizations. The need for universal primary care, which is many communities are experiencing in shortage now, activates those communities, and then activated communities can not only provide primary care to everyone in their own community. Those activated communities can provide a political base for state and federal level change. So what do we do and how do we do it? We have, as you do, we have every month or twice a month community meetings on Zoom to foster a sense of community, to information share, to create social proof, demonstrating that such an initiative is achievable. It's a focus of person-to-person recruitment, and it helps us build a database that lets us identify communities that have enough people to build local work groups from. We have created local and state playbooks to help local work groups and state work groups figure out how to approach things in their own communities, understanding there's no one size fits all solution. Communities are going to work this out for themselves. We have a biweekly newspaper that also builds community and shares knowledge, showcases involved communities or communities that are already doing this, and creates that excitement and social proof. We use local organizers. We recruit and support local organizers, people from their own communities who encourage the involvement of community members, and then we facilitate knowledge sharing among the organizers. Um, we uh, we believe in local funding of local work groups. We try our best to raise seed funding to get those local and even state work groups started, and then we support continuing fundraising from local and state family and community foundations to make this go. It's not a very expensive process. The local work groups we've got going are costing us somewhere between $5,000 and $10,000 a year. That is not a lot of money compared to the amount of money that's being swallowed down, spit out, or stolen um, in the healthcare process itself. We have local work groups now in many different parts of the country, not as many as we want. So we'd love to have one, two, three, or 10 or more in Washington. But our going local work groups are in Scituate, Rhode Island, New Bedford, Massachusetts, Central Falls, Rhode Island, Queens, New York, Alexandria, Virginia, and Cleveland, Ohio, and hopefully soon Richmond, Virginia, and East Harris County, Texas. Scituate, Rhode Island, 25 years ago, became the first community in the United States that guarantees everybody uh, primary medical and dental care. And it did that because of the action of a community of a couple of volunteers who've been meeting every month for all those years and made this happen together. So communities are the places that really have this central role. They really can organize around the need for primary care, and we see that every day because of the work we're doing in these communities. They need training, they need some initial organizing support, they need examples from other communities that provide primary care to everyone. They need a playbook of options and connections to other people in other communities where they're doing this. Remembering again that each community can and will find its own way, and every pathway counts. We've built now a sophisticated part-time and volunteer staff that punches way above its weight. We've involved more than 1,200 people in 40 states and 350 zip codes. We have people working across in these various different communities and across the country every day. A couple of hundred people who are way more than just passively involved, who are volunteering and actively participating. I will be going at 7:30 in the morning Eastern time, so not very far away your time, to the meeting of the New Bedford, Massachusetts local work group, which now involves 50 people from across the community, from different healthcare organizations, different community-based organizations, and local government. We have a robust social media presence. We do lectures and presentations like this one around the country, and we have many robust organizational collaborations from organizations that you likely interact with, and are also doing great and important work. We've learned to put our focus on providing primary care to everyone. That's the chicken in the pot opportunity. That's not taking anything away from anybody. That's giving something to everybody that many people don't have. We've learned to employ local organizers and make sure they are connected to their own communities. We've learned to partner with community-based organizations, and again, to put a local or state work group on the ground and then look for continuing support. And we've learned to keep it local and to keep our eyes on the prize. We hope to be adding 25 new local work groups a year and expanding by 3 to 5 new states a year. We have very active work groups in Massachusetts, Rhode Island, New York. We're pretty sure we've got one coming in California. We're talking to folks in Maine, in Oklahoma, and a couple of other places. And nothing would make us happier than if this group were to take this on and be primary care for all Washington, because you guys are experienced, you're knowledgeable, you're trusted, and you can make this work. When you take a step back, the history of the United States is actually a history of social movements that fix our most difficult social problems. When you look at what our government does, how Congress works, Congress doesn't change things very much. Congress makes it go slow and makes sure that we carefully deliberate, which means we don't always fix our social problems. Instead, what happens is when those social problems don't get fixed, we create broad-based social movements that involve millions of people. The abolitionist movement, the movement for women's suffrage, the labor union movement, the civil rights movement, the anti-war movement, the movement for marriage equality are just a few of those, but that's how we actually do it in the United States. And what we're beginning to understand is it's going to take that kind of social movement to fix the healthcare mess. I'm an old guy, and I don't want to be building social movements. It takes a blinking lot of work. But we just, as a group, and me and many others can't figure out another way to get this done. So we've rolled up our sleeves and said, if we build it, let's see if we can build it and see if we can get them to come. Primary Care for All Americans is building exactly that social movement, remembering that the miracle of democracy is that if the government can be used to strip away the resources needed to create health equity, then, as Jack Geiger showed us, government can be used to take those resources back and can be used to create equal and optimal health care for all Americans. So that's who we are. We would love you to join us or work with us or collaborate in any way you can think of. I mentioned Bernie Lown in the beginning, I was privileged to know and who continues to influence me. As you may remember, Bernie was from Lewiston, Maine. He was a world-renowned cardiologist. He died about 3 years ago. He was the inventor of the defibrillator and the modern treatment of myocardial infarction, described Levine-Ganong aberrant conduction pathway. He was the co-recipient of the Nobel Peace Prize in 1985 for co-founding International Physicians to Prevent Nuclear War. And what Bernie taught us was, if you can see the invisible, you can do the impossible. I think or I'd like to think that I've helped everybody to see what has been invisible, the power of primary care to be the focus of a community organizing effort, community by community, so that we start by providing primary care to all, and so that we can leverage that to do the impossible, or what's been thought to be impossible, which is to create a healthcare system for the United States that includes everybody. I'm from Rhode Island, where we have both a state motto and a state bird. The state motto is "It's okay to hope, as long as you're not too chicken." Thanks, everybody, and now I'll pause for questions.
Well, thank you. Thank you for that great presentation. And very educational, eye-opening, and I think it really gives us, at least presents a really great roadmap for what we can do going forward. And yes, I hope that our organization finds a way to help you in this endeavor.
To help
So
everybody in Washington. Because the idea is this isn't one organization or another. This is what we all do together.
great, great. Okay, well,
Great, thanks.
hopefully we've been collecting some questions that are going to be compiled and presented by John Sobeck.
Yeah, we have a couple questions to start, and I'm going to combine a couple of them. And one of them is essentially, what would you suggest addressing the increasing shortage for the needed primary care providers? And then someone had a more expansive question that said the same thing about what do you do about PCP shortages? I couldn't find a PCP for 6 months. I finally went to the ER and got one. It took over 2 months of waiting for an appointment to get a PCP. And they limit what I can talk about during those visits, right? And so it's like, once you get into PCP, are they really addressing all of your needs?
I didn't include the detailed and somewhat wonky slides about workforce. But we are in a primary care workforce crisis in the United States. We need to quadruple the number of primary care clinicians we're training. That means massively increasing the number of people, the number of medical schools, the size of medical school classes. Also true of nurse practitioner training programs, and particularly increase and often create residencies. We got to have, we can't just train more people. We got to have more places to train them. And we need a moonshot. This is not, like a tiny little thing. And it turns out, when you've spent a little time in government, it turns out that nobody is in charge of this. So we're encouraging communities to roll up their sleeves and get started doing things like starting new residencies and even starting new medical schools. I'm lucky enough to now serve on a state Senate study commission to build a public primary care medical school for Rhode Island. I don't, the WWAMI program is an example for all of us, but my guess is it could use to be 4 or 5 times the number that we have, and that's going to take a movement to push on our colleagues in government, and our medical schools and our nurse practitioner schools and our hospitals, because that's where a lot of the training takes place, to get all that stuff done.
But don't you have to deal with a little bit of the issues regarding the imbalance of reimbursement for primary care? Because even if you open up medical school, people are going to go into the higher paid specialties, and even the nurse practitioners and PAs that I know are going. I know PAs going into orthopedics that are making more than most primary care doctors are right now.
Absolutely. I mean, and that's another place where both communities and states can have a role. Communities can sort of create enough political concern so their legislators begin to approach this. We got to get Medicaid programs to dump fee for service and start paying primary care practices, and fairly and coherently. Right now, that's probably somewhere, and it's Garrison, correct me if you think I'm wrong, but I think that's somewhere between $60 and $100 per person per month, paid to the practice, so that they can keep the lights on, and pay the primary care team fairly. Trying to do this as fee for service has been idiotic. And the reason it continues to exist is that we all haven't organized ourselves to build a movement and resist it.
Yeah. So in answer to your question about, I can't give you a number. The number that it takes to support a primary care doctor is an easily determined number because we're pretty simple as businesses go. We have employees, we have an office that we have to pay rent on, and then we have salaries for the doctors. And so that number is going to be different at different locations. In rural areas, it might be cheaper because the cost of doing all this is less. Um, when I've, the thing that I've spent most of my life looking at is the question of how do you optimize primary care? How do you create a sustainable primary care? And the answer to that, I think, is first of all, you have to say the idea of having panels of 2,000, 3,000, 4,000 patients is ludicrous. That is like saying, let's go climb Mount Everest. Everybody gets a 200-pound pack, and let's see how we do. So you have to. I think panel size is the thing that I look at, and I think that originally I thought an adequate panel size was probably going to be around 600 to 800 patients. Now I think that number is probably even lower than that because we've looked
500.
at it.
Yeah.
And then the question is how you take the cost of running this practice and an adequate salary for the doctor, and then the cost of getting paid, which is like a quarter of the money. It's going to get sucked into to getting paid. So it's just not the math never doesn't work and didn't work then, won't work now. So I think that the best way to do this is to pay doctors a salary and give them sort of a target panel to have. And I think that panel should be around 400, maybe 500. And if they're taking care of Medicare patients or complicated Medicaid patients, it might be 200 or 250. And
But
then,
that's
yeah. And
well, that's
then you have to make a lot of doctors.
right.
Yeah, there's no way you do this without making doctors. Right now, our problem is not only that we don't have enough primary care doctors, but each one of them is being, tortured. And so
Yeah.
no one wants to take the torture. And
That-
yeah, and even though even if you're being paid $250,000 a year, you're still seeing 30 people a day, which means that it doesn't matter that you're there because you can't do your job.
The
So
thing I've learned from the direct primary care movement is the ideal panel size uh, is probably 3 to 500. That's the size in which primary care clinicians are rested, effective, and can sustain their work.
yes. And also you can
And
be
so
available at night. Mhm.
our colleagues who are doing panel sizes of 2 to 3,000 are tired because they're doing the work of 4 to 6 people. Nobody's told them that, but there it is right in front of us. The problem is not that it's happening. The problem is we haven't banded together to change it because the evidence is overwhelming. This is not hard. We have enough primary care doctors. We pay fairly per person per month. We get enough primary care practices scattered around communities so that everybody has access to a primary care practice down the street that's open from 8 o'clock in the morning till 8 at night and open on weekends. And all those primary care practices commit themselves to seeing everybody the same day they're sick. And what do we have? We have a healthcare system, and we probably are spending half of what we're spending now when you look at international models and make international comparisons.
Yeah. It also means that your patients, when they do get sick, talk to somebody who knows them.
Exactly.
Which means they don't need to be in the emergency room. They don't need to be in the hospital most of the time. They certainly don't need to go see somebody who's going to see 50 patients today and doesn't know them and doesn't have any way to get to know them, and then shoots from the hip because that's all they have time for. So I discovered very early doing this design that talking to a patient at 9 o'clock at night because they were having abdominal pain often, about 50% of the time, 60% of the time, you could say, see you tomorrow.
Yeah.
We'll take care of you. Here's what you do tonight. I don't think that an emergency room is where you need to be.
We know
yeah,
how to fix
yeah,
this.
yeah,
You know,
we
there's a
do.
mountain of evidence that tells us how to fix this. The problem isn't the evidence that tells us what to do. The problem is our organizing ourselves and getting it done by building this social movement, starting in local communities, working at the state level. And then when we've got, millions of people involved, then maybe we talk to Congress and explain to them what it is they need to do because they don't look like they're figuring much out for themselves. Just saying.
Yeah, well, that's also the thing I work on. That's the thing I'm retired now from clinical medicine, but the thing that I spend most of my time on is as trying to get some laws passed through Congress, which right now is well, you know how that is. But we actually have one bill that's probably going to pass this year, which is one that allows us to work for HP for self-insured employees who have HSA plans, which has been theoretically illegal according to the IRS for ever since we started in this business.
We got lots of opportunities. The
Yeah,
challenge is for us
yeah,
to learn to work together. Are there
yeah,
other questions?
yeah.
Yeah, there's a couple other
Yeah,
questions. Here's one. How do communities get money from current health insurers, Medicare, Medicaid, and commercial payers that people already have and have that paid towards their primary care?
Well, there are a couple ways of doing it. First of all, it's not all that productive to try to get money from any of those guys because they're going to try to defend the money they have. But we know from watching the Health Rosetta process and community-owned uh, health plans that if you take the health insurance provided to public employees, um, uh, uh, take those guys and assign them all a primary care doctor so that everybody's got a primary care doctor with a panel size of in the 300 to 500 range, you save 20 to 30%. And then you can open that process to other small employers in that community and build the primary care reimbursement chain process from the ground up. That's one approach. The other approach is what we used in Scituate, Rhode Island, which was we went to the town council and said, we'll save a whole lot of money if everybody has primary care. And there are a bunch of people who don't have primary care because they don't have health insurance. Can you give us, $400 per person per year and we'll just buy them primary care? And that's what we did. And that made Scituate the first place in the United States where everybody's guaranteed access to not only primary medical, but also primary dental care. Community, this is tiny money compared to what other things to other services communities do for themselves. Why not do it for primary care? It's an essential service, just like police and fire, or just like water and sewage.
And Dr. Fine, I think you kind of answered that question, but if you want to add a little bit more, one of the questions was, can you give an example of how established communities have moved from the existing mess to from the existing market to a PC for all system?
All I can say is watch this space. It's kind of starting to happen. We've got 50 people meeting at 7:30 in the morning tomorrow in New Bedford, Massachusetts. And they've got a whole bunch of different things they're working on all at once. They got to work on workforce. They got to work on creating scholarships for their kids to go to health professional school with obligations to come back home to practice. They got to work on pathway programs so their kids understand the value of health professional careers. They got to work on building a residency program. So watch New Bedford, watch Central Falls, Rhode Island. There are now 1,000 people who are Health Rosetta benefit design guys, and they're going to be repeating the Ashtabula, Ohio process of creating community-owned health plans all around the country. So you are at the beginning of a wave. You're seeing the beginning of a movement. And all I can say is we just need all the help we can get to make it run.
Another question, kind of along that line. If you dump fee for service and go to, I'll call it capitation for lack of a better model, how do you keep practices from cherry picking their patients? That's a little bit of a synthesis of the question.
Well, I think that's an administrative process at the end of the day. You need some oversight, absolutely, to make sure that that everybody has access. But one of the ways you do it is you incentivize practices to stay open to new patients. Um, and you not just new patients, but to stay open to new patients in a specific service area. And then if people can't get in, then you start having local health authorities start asking questions and trying to figure out ways of augmenting the primary care workforce in that community.
Yeah. I would also add to that that the notion that that primary care doctors are going to cherry pick is the one that we always get to hear about. And it has absolutely no application for
Yeah.
actual primary care doctors.
It's not what we
Yeah,
do. We
yeah,
exist to take care of everybody. We want to take.
yeah,
Let me tell you a funny
yeah,
story.
yeah.
The opposite just happened in Rhode Island. A 25,000 doctor practice, I mean, 25,000 patient practice, went belly up for lack of $12 per person per month. And when they began to talk about what they could do to stay alive, I said, well, why don't you just go direct primary care? And that way you can, uh, improve things. And they said, well, a bunch of our docs are pediatricians and family docs, and half of their patients are kids with Medicare. We don't want to do that because we don't want to not take care of kids with Medicare. Our guys are completely committed to taking care of everybody. They gave up their practice rather uh, than cherry pick. Um, in a way that breaks my heart even today. But I think Garrison is exactly right. Primary care docs in their bones want to take care of their communities. I don't think it's a big worry.
Yeah, I think that the real problem is having too many patients per doctor, and in such a way that you're not providing the service. The way we handled this is that we made sure that the patients are the ones who can hire and fire the doctors. And if you start getting overburdened and you can't take care of people, they simply go somewhere else. And what you have to provide is enough doctors so they got choice. That's something that will take a little while to get started, but once it gets moving and doctors know they can come here and have real primary care practices, they will have a huge of impact on the patients, and they will be paid enough to survive. Then I think that what we want to make sure is that the patients have enough of a say so that you don't need to have a bunch of administrators to make decisions for them.
Sure. Anyway,
Yeah.
maybe we do one more question, then unfortunately I have to go.
Yeah, interesting question here. How do Native American communities do it? Do they have community-owned healthcare plans?
I'm not knowledgeable, but Southeast Alaska has been doing this for years. And I think their advantage, and others probably know this better than I do, is the funding for their health care is provided by the government. So that the funding comes in per person per month or per person per year, and then they get to structure their services. That's how it works actually in the prison system, which I do know something about. They have a centrally funded process, and most people who are trying to run a centrally funded process start by making sure everybody has primary care because that's the way you make it affordable.
There's a quick question, and maybe Dr. Bliss can help answer this. And I think there may be a little bit of confusion. The question is, direct primary care practices I know charge way too much for many working poor to be able to afford. There's functional cherry picking of well-resourced, at-risk, or worried well. And I wonder if there's some confusion between direct primary care and concierge practices, which are not the same thing.
Yeah, well, direct primary care is a grassroots movement, and there's no set price that everybody has to have. So the average price nationwide is about $70 per member per month. That's the average. But that number, number can be as high as $1,000 per person per month, and nobody's going to buy that practice except very rich people. So if we want to attract, we want people to come to this price point, that then we need something that will be affordable either to communities or to individuals. But I think that the amount of money that each individual saves, and certainly that the community saves, is far more than that. It's roughly 8 or 10 times the price of the primary care. So
Remember,
the cost savings on the back end is gigantic.
remember that each of those people, anybody who has health insurance, somebody is paying $400 to $600 per person per month for their insurance. Um, and so the money is there. The question is, whose pocket is it ending up in, and why is it not being devoted to primary care practices, which are the boots on the ground for public health? And with that, I'm afraid I have to go. I don't know how to thank you all enough for your kindness in inviting me, for your attention, for your questions, and particularly my great thanks to Dr. Bliss for his years of leadership in this role. These are a couple of books in case you're interested. There's how to reach me. Please find me, and let's keep talking and working together. Thank you all very much.
Yeah, I want to thank you, Dr. Fine. This was just a great presentation. And
Yeah,
Dr.
thank
Bliss,
you.
if you don't have to go, maybe you can introduce yourself and stay on. I know that you're involved in this movement. Maybe you could field some other questions if Dr. Fine has to go.
Yeah. Who are you speaking to?
Dr.
You,
Bliss.
Dr. Bliss.
Oh, yeah. No, I'm happy to stick around.
Okay,
Yeah.
and Dr. Fine, you bon
Thanks
voyage.
for joining.
All right, I'm trying to figure out how to turn it off, but keep going on without me.
Okay, sounds good.
And Dr. Bliss, this is not a question so much as a comment. Someone said that, when they joined a primary care practice in Olympia, they were asked to fill out a questionnaire that essentially was functionally cherry picking, how sick they were and who they were going to see. Any response to that?
Well, no, if you ask people how sick they are, that doesn't mean that you're going to make your choices based on that and that you're going to avoid the sick people. I mean, you may want to know what people's medical issues are. There's some issues you can't handle, right? They're not in you're not in your scope. But I don't think that that's really an issue for primary care and even direct primary care nationwide. That there certainly are people who have gone for the money. There are people who've created practices that are bigger than they should be, and they're people anyway. So I don't think this is a big issue. I think we really don't understand how much primary care is actually worth, in part because we've created such a bad primary care system. I think $150 per member per month for taking care of adults is probably a reasonable number. And that allows a smaller panel, and it allows you to hire enough people to support the patients and you. And also it leaves you some additional money so that you can spend some thought process about additional services that you can provide.
When I was at Kaiser, we looked at some low number primary care practices taking care of the sickest of the sick. And you're talking about 300 or 400 incredibly complex patients. It was an incredibly high burnout model for some of the, especially the internists. I mean, yeah, it's only a couple hundred patients to take care of, but they are really ill patients that are not, they're not bumps and bruises and sprained ankles.
Yeah. And those people, those should probably be higher still in terms of what you're willing to pay a doctor to take care of the Medicare Medicaid combo patients, for instance. Those can be extremely complicated, and also patients who have all kinds of non-medical, social issues, psychiatric issues, drug addiction issues, and all of those things. So, at Q Alliance, one of the things we did was try to create an outpatient ICU situation. But we were charging $70 per member per month when we did that. And that still would have worked had we gotten paid by the state of Washington, which we didn't.
There's a couple of questions I'm going to put together for people on the room. I know it's not for Dr. Fine, but Dr. Lucas had one. How can new primary care graduates be incentivized to move to underserved areas? And then there was a follow-up question. Washington State, do we still have loan forgiveness programs for MD, NPPA, and affordable healthcare loan forgiveness programs? And before anyone chimes in on that, I have a daughter who's a healthcare provider who has spent 7 years in a federally qualified underserved hospital, and is 3 years away from her loans being forgiven, and that's going to get chopped off at the knees. So after spending 7 years there, the current administration is going to eliminate that forgiveness program. Any other thoughts on loan forgiveness?
I think that it would be nice if some, but I mean, if you want government to cooperate with you, I think that's a very difficult thing to do right now with any government, but certainly with the with the federal government. Um, I think that what we've come to realize is that this has to be done at the level of communities. It has to be done at the level of self-insured employers, people who care about both the patient and the cost, and are willing to follow the trail that gets them there. So I think in terms of the doctors, if a doctor is running a direct primary care practice and netting 150 or $200,000 a year, um, then they can pay off their loans. But if they're running a standard practice and they're actually netting, well, they're netting a big number, but they're also drowning in patients. And they also have to spend most of the money they make getting paid and fighting with the insurance companies. Then that's impossibly difficult to make work. So I think that if you're working with communities, they may be willing to help them pay off their debt as well, and that might be part of the consideration here. But I don't what I don't have much experience with is actually getting communities together. This is more what Health Rosetta has been up to, and what Dr. Fine has been doing.
Well, I spent my first couple of years in a practice in Anacortes that the community helped subsidize my salary because I was the only OBGYN for the community, right? They needed me and they felt like it was an important way to spend money.
Yeah, and it's not a lot of money to them, right? It is particularly if you're saving them hundreds of thousands of dollars in terms of reduction of cost of healthcare, and also improving the satisfaction of the citizens, the patients, the community that you're serving. Then I think you may be willing to pay a little money, particularly if it actually goes to the doctor, right? This is the problem. Healthcare in the United States is going up astronomically, but doctors' pay is actually not moving much over the last 30 years, which you corrected for inflation.
But I think one of the perception problems we face as physicians is anyone who makes six-figure salaries, whether it's $101,000 or $999,000, I don't think the community feels too sorry for us.
I know they don't, but they're also spending they're spending a ton of money trying to get paid just like everybody else. But primary care takes the biggest bite because they have the lowest salaries.
All right, we have about 6 minutes left, 5 minutes based on time check. Anyone can chime in about going through chat. Any other questions for the group? Oh, there was one question. It's kind of for the group and for the healthcare of all Washington people. It's see if I can find it here. Can you tell us the difference between your organization and Whole Washington and others to bring universal health care to us? And if Peter or anybody on the board can
Well, Whole
take
Washington
that question.
organization have the same ultimate goal, which is universal government-sponsored healthcare, basically single payer. And at times we've had different approaches, but our goals are the same, and we are now collaborating more. And obviously having a much improved financing system with the goal of covering everybody can certainly be facilitated by having a good primary care system. I think that could be sort of the bedrock of a single payer system for obvious reasons. But you need to have the financing straightened out. You need to get the health insurance. You need to get the insurance companies pretty much out of the picture and regulate the drug companies and just dismantle the medical industrial complex in various ways. And that will open up opportunities for primary care and my field, which is psychiatry, mental health. It's going to provide a foundation that'll help all the things we've been talking about tonight, I think.
Yeah, that was my discovery early on, which was no one was going to save us. And the only way to get optimized care was to create it, figure out a way to pay for it, and then eventually get big enough so that that communities and governments will start to say, "How do you do that? You know, how does that? How could you possibly do that? Why? How could primary care doctors actually make a living?" We've talked about the rural problem. So with direct primary care, you need a panel of 400 people to support you, right? Not a panel of 2,500, so you could take care of a small community. And if you have a thousand, 1,500 people in the community, you can get two or three doctors, and they can share call, and it works. Everything works. The money works, and the care works. And so if you wanted to solve that the rural problem, the way you do it is with something like this.
Yeah.
And the government can't figure out how to do that for some reason.
The one
Right?
thing I would challenge a little bit, Dr.
Yeah.
Bliss, is
Mhm.
that potentially could you take care of a large number if you assume that not everything has to be done face to face? And I think in healthcare, for some reason, we believe that the only visit of value is a face to face visit, and you can do a lot of care remotely through email and virtual visits, and especially for people who aren't that sick. I think if people don't have to come into the office, you could potentially take care of a little bit larger panel size.
Well, um, I don't know if you know much about how direct primary care works, but we have a monthly fee and we do not charge insurance. We're not part of that. So we don't, you can do, we were probably the earliest people to say, oh, well then we won't just see you in the office. You don't have to
Right.
call and make an appointment. Here's my cell phone number. Here's my email, and here's how you text me. And I'm
Yeah.
available on all three channels pretty much all the time. And that sounds to most doctors like a scary moment, but then you say, oh, it's 400 people who you actually know and like, and they like you.
Yeah.
So it's like your friends call you and you solve their problems. Anyway, I don't think that this is an impossible to solve problem. I think it's just impossible to solve if you think that insurance companies have to be engaged with you on this.
Yeah.
And
On
I
that
don't
note,
think they're necessary.
yep, I agree. On that note, we're gonna have to sort of
Yeah.
bring this to the end. But it's my job to end this meeting with a pitch. Sorry, guys. And you've been hearing some wonderful ideas tonight, and our organization is involved in all kinds of wonderful things, and we're going to get more involved in this kind of thing, I think. We've been involved in many legislative actions over the years, educational actions. And if you want to get an idea of what that's all about, just go to our website, look at all the things we have done and are doing and will continue to do, including working towards single payer. We have a bill, Washington Health Security Trust, which is 30 years old. We're just going to keep reintroducing it. That's our holy grail, which is to create a single payer healthcare system in our state. And we have a wonderful lobbyist, Lonnie Johns Brown, who does great work in Olympia. We have our board members, volunteers, other kind of supporters are very much involved in our organization. We educate. We have great relations with many legislators. But these activities require financial support in terms of personnel, outreach efforts, administrative support. So please help us continue this work by making a donation tonight. As we've mentioned, there's links in the chat. So please give us some money. That'd be great. And we certainly appreciate all your support. And together, if we work together, we can achieve our goal of cost-effective, high-quality universal healthcare in our state. Thanks, everybody. And come next month.